Hey folks, I'm Scott Weingart, and this is the EMCrit podcast. Today on the podcast, a ultra-friendly debate on ED pharmacists in the emergency department. And just as a quick foreshadowing so you don't get your hackles up, I love ED pharmacists in the emergency department. I love ED pharmacists in the critical care units. But today we'll be looking specifically at emergency medicine. And to do this debate, I have probably the perfect guest, Megan Reck. And she'll introduce herself, but she is brilliant, and she is actually now at the national level doing advocacy and representation for ED pharmacists, so couldn't find a better guest. And I think you're going to like it. Now, I'm super curious to hear what you think. So please, after listening, go to the webpage and put in your comments because I want to know what you think about the issues raised in this episode. Let's get right to it. So we always start with the same question. Who are you and what do you do?
Hi, my name is Megan Reck, and I'm an emergency medicine pharmacist and research health scientist.
Absolutely. And Megan, you're a frequent commenter on EMRAP. You have been on with me there before. I've enjoyed working with you. And you also have a role, I think, at a larger nationwide level. Why don't you tell them what you're doing with the group inside SAEM now?
Yes, thank you, Scott. I am the inaugural president of AMP. It's the Academy of Emergency Medicine Pharmacists. We are the latest and fastest growing academy within SAEM.
All right, so that means you're not just commenting personally. You don't represent that group on this podcast, but it does mean that you have numerous people you've spoken to at a nationwide level, that you are really, I think, on the pulse of what's going on with ED pharmacy. Is that fair?
I think that would be accurate.
All right, cool. So the reason we're speaking is because I had made a comment, which I had made many times on MRAP and on EMCrit, that in some ways, and as my priors, I love ED pharmacists. I've fought for ED pharmacists at every ED ICU I've staffed. I will really put my foot down that I don't think it's safe not to have ED pharmacists. So you're not going to find a detractor here. But I do think ED pharmacists in their current form in many places are de-skilling emergency medicine nurses and emergency medicine physicians. And you took a little bit of umbrage at that particular term. We'll see if we disagree on the conceptual level, but at the level of the term, you're like, come on, Scott, let's phrase this more positively. So tell me about that, Megan.
Yes, there's 4 reasons why that term de-skilling makes me cringe a little bit. First and foremost, my commitment as an emergency medicine pharmacist is to the patient, to ensure that meds are delivered in the safest, most effective, and most timely way. And the way that I approach patient care is totally different from how a physician or a nurse approaches the patient. When we have a sick patient that comes in, I am thinking about the pharmacology of medications, the pharmacokinetics and dynamics, drug interactions. My first priority is to always figure out, what is the patient taking? Could a medication be causing whatever this situation that they're presenting in is? And so we augment care in that way that's completely unique from physicians and nurses. And I think the phrase de-skilling is a bit physician-centric and loses sight of why we are there in the first place. And if I'm doing my job well, I hope that my physician and nurse colleagues should feel empowered to manage medications in the safest way possible and not diminish their skill set. So that's the first reason. Second reason, I think it's unlikely that if a physician were to work with an emergency medicine pharmacist who takes some of the cognitive load, like post-intubation and algo sedation, which is the latest example in which this term was used, that they would become so de-skilled that they couldn't adapt to a future setting without those services. I think by that same logic, a nurse placing a Foley, for example, or a respiratory therapist initiating a neb, would that erode a physician's skill set so much that they couldn't adapt to another setting or another ED without that support? I don't think so. I think most physicians that I've worked with, they're awesome. They're in emergency medicine because they are so adaptable and they're able to adapt to whatever learning curve may come from a new setting. And so I think that they could transition to a new role without us, where hopefully they take what they learn from us and apply it in that new setting. And then we really need to practice at the top of our license because we have trainees. We have emergency medicine residents across the country. We've seen really a great expansion of EM residencies for pharmacy residents across the country in the last 20 years or so. And they need to see what it's like to practice at the top of your license because many of them are going to have to go on to new settings where they're starting new service lines. In my last job, where I was at for over a decade, I had to start a new service line, and it can be really intimidating intimidating to go into a department, and they need to be equipped with the best skills possible in order to do that. And then finally, I think the term de-skill just really carries a negative connotation. And if someone is considering hiring a pharmacist in their ED, and they hear that from someone who has a lot of influence and is very widely regarded and respected in emergency medicine, I wouldn't want it to have a negative impact on our growth. There are still about 50% of EDs in the country that do not have emergency medicine pharmacists, according to a latest workforce survey. And so that is likely inflated because of the respondents. There's probably some selection bias. So there's still at least 50% of EDs in the country that do not have ED pharmacy services. And we're growing a lot, and we've really seen a huge expansion in the last couple of years, but we need to keep that momentum and not detract from it. So those are all the reasons that I reached out, and I just really fundamentally do not like the term de-skilling, as I think it detracts from why we're there.
Yeah, I'm not going to argue the term. I think the term is perfectly apt, but I could hear why it might rankle. I'm going to argue the underlying concept, which I think is the more important thing. We'll see if we agree or disagree. So let's pose a situation in which a ED is lucky enough to have 24-hour ED pharmacy support. And they've just realized there are medication errors with things like PCC administration, thrombolytics, when people are still using alteplase versus tenecteplase. And they've just said, you know what, it's smarter for us to be finding out the patient's true weight, drawing up this medication appropriately, making sure it's provided in a way that is safe and as error-free as possible. Now, you could easily see that would be something that would be tasked to ED pharmacists if there was 24-hour coverage. Is that right?
If there's 24/7 coverage, then yes, we play a big role in things like administering thrombolytics.
Sure. Do you not agree that in a situation like that, the nurses, if one day there just wasn't an ED pharmacist available, they just could not cover their service line because one person was sick and there was no one around to cover, would be in a situation where their skill set for the administration of those medications has significantly declined to the point where it actually might cause a patient safety issue?
I agree that if there's 24/7 coverage and nurses never touch thrombolytics, that a problem could arise from no one being there. But you have 24/7 physician coverage, you're not going to open an emergency medicine without a physician. If you have 24/7 coverage, there's not going to be a situation where a pharmacist is not on shift. I work in an ED right now where we have 24/7 coverage. And you may collapse a little bit because there are times where we have multiple pharmacists on service because it's quite busy. You may collapse down to one person, but you're never going to have a situation where there's just no one filling that shift. And I think that should be the commitment if you are running 24/7.
I think you're slightly avoiding the question that you know is being posed. I could keep going with the particulars to find the situation that you know you're going to be in, Megan, which is there will be a circumstance. I will give you 2 patients coming simultaneously. I will give you, I could give you 100 variants, but you know the answer. Yes, it de-skills those practitioners.
I will agree with you on that, but I also think that my job as a pharmacist is to make sure that when we're doing things like reconstituting thrombolytics, that I'm educating the people around me, including my learners, including the bedside nurse, including the resident physician who maybe has never seen a thrombolytic being used, that I am explaining to them what the process is so that if they need to see it in the future, that they're able to do that.
Yeah, I'm sure you are. I think we do agree. And look, I'm not going to push you on it, but we do agree. They do de-skill. You don't like the word. I understand you don't like the word. But pharmacists in their current role may have some movement towards de-skilling. Now, I think what I really want to talk about is how we could avoid that entirely. And you've mentioned one way, and I think that's wonderful. I think there's better ways. And that's what I wanted to talk to you about, because we're really at the point where ED pharmacists could establish their identity. I think critical care pharmacy has really, their identity is established. We know exactly what a critical care pharmacist does, and they are essential to the team, to the point where I don't think you should have an ICU that doesn't have critical care pharmacists in the ICU with you. Now, whether they're 24/7 or not could be argued, but their presence is inarguable. And I think we're at the point that should happen in emergency medicine as well. So we're really at this critical moment where the identity could be really established. And I think ED pharmacists in some ways are going the wrong direction in establishing their identity. And I'm going to justify that statement. We'll see if you could agree, Megan. So how would you characterize the role of emergency pharmacists in the emergency department?
I like to think of us as a consult service where we're available for whatever you need.
Yeah, I think it's very dangerous to call yourself a consult service. That's establishing an optionality that I don't think should be there. In my mind, the doctors and nurses are the direct patient care providers. And then other health professionals like emergency pharmacists are essential, but are not allowed to provide direct patient care without the direct providers. Meaning, you would not have an ED pharmacist seeing a patient come in the ED and discharging them, which in the future may happen. But what they're there for is an essential role that is in parallel with the direct providers. The direct providers are providing the general care in the emergency department, the primary care of those patients, and other health professionals are providing essential services that are necessary, but will not allow the true like you could have ED patients coming through that never see a pharmacist because there are some roles that they will serve for our patients and some they won't. You're never going to have a patient not being seen by direct patient care providers like nurses and doctors.
Yes.
So now if we define it this way, then we could look at the other health professional that we deal with in emergency medicine and ask ourselves, did they go the right or wrong direction? And many of these health professionals, I think, have gone the wrong direction. Now, I'm not going to name which professions because I might ostracize listeners. But in all these professions, I think they are essential and key. And I've had in all of these specialties, have them save my butt numerous times. But there's particular fields of health professionals that have decided from the perspective of absolutely ensuring that their jobs are not going to be cut, that they are going to be safe, that they've gone from this progression of let me help to this is ours to don't touch to you can't touch. And I'm not going to name the profession, but you're smart enough, I think, to understand some of these health professionals that this would immediately slot into. And then I have to spend a year of my life whenever I start a new unit explaining that no, as direct care providers, this is ours. And the fact that you help me with this is immensely beneficial. And there are things you know about this that, are going to really help. And for more junior people, it's going to help a lot. For more senior people, you're going to save their butts once every few months. But don't tell me I can't touch the machine. That's not going to work. A, you're not there enough. And B, that's not your job. Your job is, as you alluded to, Megan, to be consultative. And when that's established, then we have wonderful relations with this health profession that I'm not going to name. Now,
sure.
Pharmacy is at the point where they have a decision to make. Do they want to be at a level that is duplicative and it's going to just really, we do this more safely, we do this better, or do they want to really own their unique slot in emergency medicine? And I'm putting this in very figurative terms. So let me make this literal. I don't think pharmacists should be drawing up meds. I don't think pharmacists should be preparing the TPA. I don't think pharmacists should be doing any of that crap because it does de-skill. And it's not operating at the top of their license. What pharmacists know better than anyone else in medicine is medications, how they should be used, how they mess up in individual patients, how they mess up when combined with other medications. And there is more than enough role for that. You mentioned cognitive. That's where they should be operating. And now imagine a situation where the pharmacists are intimately involved in the training of nurses and doctors on medication, drawing up and utilization, but they are not doing it. Now, it doesn't mean they can't help out. Like you have a crashing resuscitation and many nurses are involved in setting up the CPR and all of that. Hey, do you want me to draw up the infusion? Yeah, of course. But that's not really their role. They're helping out in a role that is clearly still in the purview of nursing. If pharmacy starts latching on to the hands-on stuff in the emergency department, then that's where they're going to be in some way restrained to. And I think it is a waste of the skill set of ED pharmacists. So let me say that and leave it there for a sec, hear what you have to say, and then I'll go further in trying to establish a identity for ED pharmacy.
Sure. First of all, I hear you. I do think that we have a responsibility to make sure that every medication that we're using, that we're communicating why we're doing things the way that we're doing and what are the safety concerns behind whatever medication we're using. And I do often, I have the nurses do a lot of hands-on things. For example, I was just working a shift and the nurse I worked with had never administered adenosine in a single syringe. And so I walked the nurse through how to prepare it, walked her through why it makes sense to administer it that way. You don't need two people. You don't have to worry about switching over the stopcock. It just makes a lot more sense in order to maximize it getting to the heart. And so that's an example of how, sure, I could have just done it for the nurse and maybe it would have worked. And then the nurse would probably never carry away the skill of how to do that again. And that may be a situation where we're really busy. Where I work now, sometimes there's multiple critical resuscitations going on at the same time. And I have to decide which one is more important for me to be at and how to kind of pivot between multiple sick patients. And so those are things that I do feel is very important to upskill the nursing staff and the physician staff with. But I think that a lot of times in an emergency, it's impractical for me to just stand there and give orders when I could be helping and being hands-on. And I also think being hands-on is very important for our learners. It's really important for them to have that power of whatever I recommend, whatever I dose, I give to the patient. It goes directly to the patient. And so I think that there's an ownership in that is hard to retain if you're not actively involved at the bedside.
Yeah, I like the active involvement. I don't think they should be hands-on for the same reason that I try not to be hands-on. It's no different, Megan. I could take over every aspect of that resuscitation. And you could make an argument that the patients would actually benefit. I am far more experienced than my learners by about 20 years. But I don't do that. I don't take over the central line until I see them failing at it multiple times, even though you can make the argument that I'm going to do it much better on that first try. I don't take over the intubation, though inarguably, my first pass success is higher than any of my learners. The reason why is because they won't get the skills otherwise, even though an argument could clearly be made from the patient benefit that me doing every single procedure in that resuscitation would be the best thing for the patient. But we're not there just for the patient, Megan. We're there for the patient, the learners, and the system. And that's why I think ED pharmacists should be hands-off, except in a circumstance when the people are so struggling for hands that they could help out. But it's a help out. Just like me, sometimes I'll throw in an art line as the initial person doing it because all of my learners are test saturated with other things. But my job is not to be the primary person putting that art line in. And I think if pharmacists start adopting that mindset we've just established, which is, yes, absolutely, you could help out, but that's not your role. You shouldn't be hands-on. Then all of a sudden, we have pharmacists that are performing at the top of their license, rather than both de-skilling the nurses and wasting their time. Megan, you can't tell me you're doing direct med administration and are going to have the same cognitive bandwidth to be evaluating that patient's med list when they come in as the primary source of what the hell's going on with them. I would much rather you have in that resuscitation figuring out, hey guys, you think this is sepsis? It's not. This is like a horrible aspirin toxicity. And you're not going to be doing that if you're drawing up the norepic.
I think that's a fair point. And I do think that the longer that I get into this, I'm almost 15 years out of residency training myself. I do try to maintain that sort of attending pharmacist model, especially if I have multiple learners in the room like you would with medical students. And my job is to make sure that they are functioning as that emergency medicine pharmacist. So they are getting the meds out and we're discussing those things, much like you would with your learners. So I think we have to get the most critical medications to the bedside at the time that the patient needs it. But also, I am thinking about those things like what is the cause of this patient's presentation? What medications are they on? Oftentimes, we're multitasking in the department.
Yeah, for sure. And look, I don't want to belabor this point of the argument any further, but I will say I would be much more comfortable with the pharmacist role if the hands-on was left to the nurses and the pharmacists were training the nurses in ideal medication administration, creating the systems for the department to make sure those things are done safely, breaking down bottlenecks and roadblocks to medication administration, but letting the nurses stay hands-on. Because the nurses already are so undertrained with our current crop of resus nurses because of the mass egress of COVID that even the nurses who had veteran level skills, they're usually gone. And now we have a whole crop of new learners. And yes, they will see maybe and try to imitate what the ED pharmacists are doing. There's nothing more effective than forcing a person to own something to allow them to want to get the ideal skill set. If you tell the nurses, you have to be able to draw up PCC and thrombolytics, they will come to the pharmacist and say, help me, I don't know how to do this, I've never done it before, versus, hey, I'm drawing this up. Does anyone want to see it being done? Come gather around. They have other stuff going on. They're too busy. It's not going to happen. Okay, so if my dream of no hands-on except when absolutely needed happened, now what are the roles of an ED pharmacist? You've already mentioned one, which is I think that any resus patient, and I'm going to say this, and I don't know if it's possible with the current staffing, but any elderly patient should have their meds evaluated by an ED pharmacist. This 80-year-old who has 30 medications that I could guarantee beyond a shadow of doubt there are interactions that are negative and shouldn't be there, but I don't know which ones they are. So do you accept this as a good role of an ED pharmacist? Is every resus patient and every elderly patient, let's say greater than 75, gets their meds looked at by an ED pharmacist?
Yeah, I totally agree. Polypharmacy, adverse drug events, falls, delirium, all of that is very common in elderly patients. And so those are definitely patients that we do try to prioritize.
Now, at some point in the recorded discussion, the word med reconciliation came up, and Megan and I went back and forth, and I clarified that I don't mean pharmacists should be doing the med rec. I don't know who should be doing the med rec. Most of the time the med list we get it's fine. It's accurate. That's not the problem. The problem is no one's looking at the interactions. No one's looking at whether these meds are necessary or helpful. And that's the role I'm talking about here. So we determined that there's not really a word for that. I'm calling it medication review. I think every resus patient and every elderly patient should have a medication review by an ED pharmacist. And who has to do the med rec, whether that should be deferred to inpatient, whether there should be pharmacy techs, whether it's going to be the ED doc, which is by all means the worst possible way to get it done because we are effing useless at this. That's not what I'm talking about. I'm talking about figuring out, does this list make sense? Is it contributory to the problem the patient's having today? Is it going to contribute to a problem the patient's going to come in 2 weeks from now? And I think that is a wonderful role for ED pharmacists.
And which ones to start when we actually are now putting orders in the ED, which ones should get continued, which ones should get DC'd. That
I see
is a role that is not being filled by anyone because we're pretending the docs are doing it, but they're not doing it well. And that is a role I would love to see ED pharmacists. Now, resus is really the critical time for that, but the elderly now, especially with this focus on geriatric emergency medicine, that's like medication-related presentations are so prevalent and so under-recognized, that would be enormous. So yeah.
Hey folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed. And you never have to hear this message again. Please consider joining. And thank you for listening.
I would love techs or whoever to find a list. If that's even, they bring in their med list. I don't care, honestly, what the exact dosing is. So much as, oh no, this is the exact reason this patient's here with altered mental status is some joker started them on X and not recognizing they were on Y, Z, and Q. And that's probably what's causing this. So I think that is an incredibly vital role for ED pharmacists.
We need a quick name, yes.
It needs to be a name. That is, I think, an incredibly vital role.
Medication optimization.
There you go. I love it. There you go. Medication optimization. All right. I think they should also have a role in when specific antibiotics are ordered. It should be an automatic queuing. For instance, vancomycin. It should just, I know some places like Stanford, you don't even order dosing for vancomycin. Order vancomycin as per pharmacy. And then the pharmacist gets involved. They determine here's the proper dose given the patient's clinical scenario. They look for things like renal adjustment. They figure out the entire dosing package. That is essential in a critical care unit. I think it's incredibly beneficial in an ED as well. I would love all vanco dosing to be done by an ED pharmacist.
I think a lot of emergency departments have a similar setup. In the emergency department I work in now, we very rarely use vancomycin and linezolid as a workhorse. And even then, we're reviewing really all antibiotics. A huge part of our job is antimicrobial stewardship. And that includes setting up the protocols, pathways, guidelines, whatever you call it at your institution, to make sure that when the physician is going down that pathway to order whatever they suspect is the etiology of the infection, that they have the appropriate antibiotics.
I love it. All right. So now you mentioned really taking over. And I hate this stewardship idea, though. I guess that's the best term we have for it, because it always implies holding off from letting those folks do what they. And for me, stewardship is also giving really big antibiotics when appropriate. Mm-hmm. And so, yeah, I guess I shouldn't even argue. The term's fine. Okay. So that one's a good one. But it's crucial. And I've been in places that have done it the right way and the wrong way. The pharmacist must be able to actually change or place orders in the system. And I've been in places where it's like, they have to go to the doctor and say, hey, could you reorder this Vanco? And it doesn't work. At your place and at the places you advise, is that how it is? That the pharmacists are actually able to go in and change and make orders?
Okay, it sounds like, Scott, I'm descaling the nurses, but you want me to do orders for the physicians.
Only because the game telephone, we just said this is going to be a main role you have.
Sure. So if I'm placing an order for something, first of all, I try not to place orders because I want the physician to take ownership of the orders. And I want them to remember, if I just place an order for the second dose of antibiotics, say I have a boarder that's been there for a while, MICU hasn't picked up the patient, they're due for the next dose of whatever, Zosyn. And if I just place that order and I don't tell the physician, then maybe the next time they see a patient in that situation, it won't trigger their thought process to like, oh, I should be thinking about the second dose. So I'm definitely paying attention to that, but I might not necessarily be placing the order for it. I'm certainly going to communicate that.
No, I didn't state it as well as I would like, Megan, so let me revise that.
Sure.
If I say Vanco dosing as per ED pharmacist, then I've already accepted that they're going to be placing that order.
Sure. In that case, I'm happy to do
it. And then swinging back and saying, here's the Vanco I chose, I think would be a beautiful thing for the ED pharmacist to do, because then it will train them if they go somewhere that doesn't have that. On the other hand, you're absolutely right. If it's something like a missed second antibiotic dose that wasn't ordered, they should be ordering it, because that was something they should own, that they've had an error. And it's the same thing with the antical sedation for intubation. I think the docs should be ordering that. And if the ED pharmacists realize this patient still doesn't have orders for it, then they should point out, just like I would as an attending ED critical care doc, guys, what's going on? There's no sedation orders on this patient for it, rather than
That's
taking
exactly what I do.
Yep, we're in complete
Exactly
agreement.
what I do is say, I need you to order analgo sedation. Here's what I recommend, but I want you to order this so that they remember the next time.
No, we're in complete agreement. All right, next thing is, ED pharmacists should be the interface with pharmacy. Now, this seems obvious, but it really, and this is going to be a tough one. We'll see if you're able to answer this, Megan, in a fashion that won't put you in a bad spot. ED pharmacists need to own that they are part of the ED team.
100%.
Yeah.
We are part of, I am employed by the pharmacy department, but my job is to represent the emergency department to the pharmacy department and be physically the presence of pharmacy in the ED.
Okay, now I thought it was definitive, but we'll see if it really is. Okay, so you have to choose sides. The problem with ED pharmacists in many places, and it's not their fault, it's the position they're put in, is they're asked to be on two teams. We're team pharmacy and we're team ED. It doesn't work. You can't be on two teams. Now, 99% of the time, there's not going to be any conflict with the two teams. But the 1% there is, you got to pick a side. And if you're going to be an ED pharmacist, I think you got to be on the ED side. And
I guess I don't see it that way. Perhaps the conflict is not as apparent to me, but yeah, absolutely. I'm first and foremost an emergency medicine pharmacist. I understand every role in the pharmacy. I think it's very critical that anyone that works in a clinical role in the emergency department, that you understand how the drugs are made, where the IV room is, what to do if, you need something that's critical, and how to communicate that to the pharmacy team, because there can often be this tension there where I think something is critical, and what that means to me is I need it now, and they think something is critical, and that means we need it within 30 minutes. And so that is often misaligned, and that's where having a relationship with the central pharmacy and the pharmacists that work there is really important.
100%. And that was actually another item on my list. Is you took the words right out of my mouth, which is stat meds at every hospital I've worked at are either 30 or 45 minutes, which is stat maybe on a floor. That's not stat what we need in emergency medicine. So yes, ED pharmacists could actually interface and make that happen. But I'm talking about something a little bit different. Let me give you an actual concrete example because I think it'll better represent what I'm talking about. So local anesthetics for wound repair. Now, from a pharmacy perspective, and it makes complete sense in my mind why they would want this. They want that in a Pyxis with patient assignment of those meds each time you need it. That is so deleterious to ED workflow. What the ED docs want is a locked drawer with fully stocked of the various ropivacaine and lidocaines there so that as we're taking our suture material and we opened up the cart, we then take our lidocaine or our whatever we need for that patient and we go and we do our wound repair. Now, there's a conflict there. Pharmacy has very understandable viewpoints why they would want to know individually where those meds went and which one was taken for each patient. And the ED's viewpoint makes complete sense. So who wins in that circumstance?
Scott, this is so funny that you bring this up because we are changing this over at my department right now. Right now, lidocaine and lido with that be our floor stock, and you can just go in and grab them, and we're adding them to the Pyxis. And so I understand completely, and I think that as clinical pharmacists, we're often at the intersection of those decisions and trying to do what makes the most sense for patients. I'll tell you, 99% of the time, I don't care if the patient gets a dose of lidocaine or lidocaine with epinephrine, but I do want it documented appropriately. And that's where I fall on the side where we should probably place an order for it and we should probably remove it so that we know that the patient actually got it. Because when you have floor stock like that, then it tends to not get documented 100% of the time. And then if the patient has an adverse effect, local anesthetic toxicity, then you want to make sure that you document the dose that they were given, the time that it was given, so that we can act appropriately. So I think every case like that is nuanced, and our job, we're considering all of those angles and making sure that we are optimizing medication safety.
Yeah, I think you've made the wrong decision in your department. And what you take out of the Pyxis in no way establishes any sense of what the patient actually received. It couldn't, because there's no possible way at the time you're taking things out of the Pyxis or placing an order to have any idea what the patient's going to receive.
That's fair. We don't give 100% of what we're taking out.
You couldn't, because if you took out what you predicted as 100%, you're guaranteed in a vast majority of the time to have inadequate anesthesia for that patient, because you figure out, okay, here's what I'll probably give, and then take out twice that much is a reasonable way you play it.
I'm in agreement with that.
And you're still not establishing any patient safety type stuff. If there's a problem with documentation, you have to enforce documentation. I really don't think there's a single instance where the docs were suturing a lac and didn't say injected lidocaine 1%. They always do that. So did they give 7 cc's and wrote an order for 5 or put it in their suture note 5? Maybe. Who cares? That's not what we need. What you're alluding to is if a patient got a large volume nerve block and had an incredibly rare adverse event, then we want to be able to track it. Well, okay, in that circumstance, what they took out in the machine still doesn't give them the answer. That has to be actually speaking to the clinicians involved and saying, hey, how much did you actually give? Oh, we only gave 10. Okay, but how many bottles did you take? We took 3 bottles. Okay, but you didn't give those? Oh, maybe we gave more than 10. You still have to do the retrospective analysis of the situation with the clinicians involved. And so now you've really given an enormous workflow hit to every single procedure done in your department, to a benefit that I don't see. Like, that's the exact thing I want the pharmacist saying, hey, we understand from the viewpoint of the pharmacy why this would be helpful or may be helpful. But in reality, it's actually incredibly detrimental.
It's also really detrimental if we run out of lidocaine in the department or lido with epi, or there's a drug shortage and we don't know how much we're using. And adding things to the dispensing cabinets helps for more than just maintaining.
You know, Megan, that the pharmacy tech, when they come by, could look in the drawers and see how much is missing, and that is how much is being utilized on a daily basis.
Yes, but we're adding a separate workflow for the pharmacy tech to do that. And you want to talk about turnover in nursing. There is so much turnover in pharmacy techs and much less training that goes into being that. And so that's a recipe for disaster too. So I agree. I really do try to be the liaison and advocate for the emergency department as much as I can in that role. And oftentimes I feel like the things that I'm advocating, for example, like they really fought me on adding PCC to the Pyxis machine or adding even hypertonic saline, 3% saline. I had a hard time getting added to the Pyxis machine. It took me years to get it added, to make the argument that this is a safety concern, having to wait for it to come from central pharmacy. And then I was running all the way across the hospital to pick it up every time we had a patient that needed it. So I think that's definitely our role, being that liaison.
Absolutely. And they should be representing on the P&T committee so that emergency medicine actually gets heard. But yeah, you've mentioned some issues that I think ED pharmacists could win on, and that having a organized group like you're establishing can establish baselines nationwide for it should be 3%. There should be a list of resuscitative medicine that is immediately available in the department so that it's not an individual fight with each pharmacy at each hospital. It should be universal. 3% is immediately available. 23.4% is immediately available in the Pyxis. We could bring up the next one. You and I had a discussion/debate on push dose pressors. And there's been an enormous amount of ED pharmacist-led papers placed in the literature on this. Now, one has to wonder about what the true objectives of all of those papers are, because they're all talking about the medication errors that happen when physicians are involved in the drawing up and utilization of these medications. And so I'm not going to go into the philosophy of that, but I think it does speak to identity. I think either ED pharmacists should be training the staff on how to utilize push dose pressors such that they are now done safely at a system-wide level, or ED pharmacists should go down at the beginning of their shift, if they're not 24/7, and take an amp of epinephrine and create 10 syringes of push-dose epinephrine under the hood so they have a longer duration before expiration, and figure out how many you need for your department. Maybe it's 10, maybe it's a 20 a day, and bring them up and put them upstairs. And then we'd never have this issue again. So instead of putting all these papers in the literature, let's solve the problem.
Yeah, I think some of those papers are in existence because it recognized a problem in the first place that we need to solve. And I think a lot of places, I have pre-filled syringes of epinephrine now. So I'm not going to have that issue of push dose pressors resulting in the patient getting way too much or being administered incorrectly. So I think at a lot of places they have solved that problem, but we need to do studies like that in order to show that the problem exists.
Did they, or could they have just solved the problem? I think, I won't belabor it, but I think those papers and their prominence was not just happenstance. And I think attempting to establish a job role that I don't think the pharmacists really want.
I think that's fair. I think a lot of the papers that we do to try to justify our own existence are because we do have to justify our own existence.
Yes.
It's crazy. Like my hospital, when the pandemic hit, you know how many pharmacists were fired? 12 pharmacists in our department, and we all had to pick up everything else. So it really showed that it doesn't matter how much you save in terms of medication costs. It doesn't matter what novel initiative you're trying to start that will save the hospital money. At the end of the day, when finances get tough, we do get let go, and we do constantly have to justify our own existence. It's why we've done a lot of cost avoidance literature. People hate cost avoidance studies. The C-suite hates cost avoidance, but we have to show that what we bring to the table, because when things get tough, we are on the chopping block, unfortunately.
No, absolutely. But I think we take that absolute truth and we send it in different directions as to what should be done. So in my mind, anything that establishes the necessity of pharmacists for direct hands-on skills, like administration of push dose pressors, will be the first thing cut, because there's no one who cannot look and say, let's just train the friggin' nurses to do it. Let's just train the doctors to do it. Versus, and that's why I think any place that's using 24/7 pharmacist coverage is going to have a real hard time when the belts get tightened, because that's going to be a tough thing to justify. But if you had an absolutely essential role of an ED pharmacist in a department that is doing all these cognitive tasks that cannot be done by anyone else, that's job security. And it's the job security you want, because it's not, I've been asked for 15 years now, when people are establishing ED ICUs, should we do it as a standalone unit? Meaning the ED is doing resuscitation and then they send them to the ED ICU
after that initial stabilization is done. And some people have gone down that model. And I beg people not to take it, even though it seems incredibly appealing, because you're always on the chopping block. Any administrator in the C-suite looks at that and says, that is a bonus. Yeah, it's great, but why can't they just go up to the ICU when a bed's available and the ED could take care of them until then? Let's get rid of that unit and take that personnel and that space and do something else with it. Versus what I've always advocated, which is you establish a zone that's doing both resus and ED critical care, and you are offloading the rest of the department. You cannot get rid of it. You can't chop that. The entire department would shut down. There's no one else doing it because that's where all the resus is happening. If you have ED pharmacists doing roles that are beneficial to get 24/7 staffing, to get all these slots, they're going to be cut at the first possible thing. If you establish the absolute bedrock, which is 8 to 10 hours a day, there should be an ED pharmacist at the peak hours there to do all of these cognitive tasks that cannot be done by anyone else. That's going to be a role that cannot be taken away. And then you could expand past that, but with the knowledge that the more you expand, the more you are putting your head on the chopping block. How does that sit?
Well, I think that a lot of places that have gone from no ED pharmacists to 8 hours of coverage or whatever and eventually expanded, I think we are taking on some of those responsibilities for the department that are essential, including things like the physicians that I work with. They don't necessarily want to own all of the order sets and guidelines and all of the administrative things that come with optimizing medication safety. We also wear a lot of hats in terms of QI, doing QI conference, anything that pertains to a medication error. So I do think that we become essential in those roles. It's very difficult to translate, I think, to the C-suite what exactly all of that entails. You can't run a department without a physician or without a nurse. I think it's harder to see why you can't run a department without a pharmacist, because those things can be picked up by other people. It just is not going to be through the same lens of medication safety.
Now, I'll give the example of you can't really run a department without someone in charge of ED ultrasound. There needs to be someone who's doing review of those images, making sure the machines are purchased on a regular basis, making sure all of the equipment we need is there. You can't run a service without a variety of things. And I don't think you can run an ED without an ED pharmacist. And that role, if you tell me 50% have none, then that's the low-hanging fruit, because they need at least one.
Absolutely.
And it might be that their role is mostly at a leadership administrative level, and then they're doing hands-on as a bonus. And I think that alone is where the enormous expansion of care occurs, is from 0 to 1. And
Absolutely.
then 1 to 2 is still big bonus. But then as you continue the around-the-clock staffing, the benefits fall off to some extent, and they don't fall off enough that doesn't make it worth it if you could afford it. But I think in some ways the C-suite is right. To go from 0 to 1 is a investment that every ED should force to happen. From 1 to 2, if you can. From 2, which it allows that peak hour coverage on a regular basis, to 24/7. I'd love to take it if I could, but I don't think that's where I'd put my money if we're tight.
Yeah, I'm in complete agreement with you that it's insane that there's so many EDs across the country that do not have pharmacist services. Even from an optimizing their order sets and pathways and how they're ordering medications alone, that ensures. I worked for a long time at a department where I was the only one at first, and then we expanded to 2 pharmacists. So we offered 12-hour coverage a day. And I spent a lot of time thinking about everything that we implemented, making sure that if this happens, that 24/7, they're able to accommodate, because I can't be there 24/7 with just me. And I don't want them calling me at 10 o'clock on a Friday when I'm out to dinner with my family or whatever to try to troubleshoot some situation. And so how do I make it so that it operates at a high level all the time? And so that's definitely what adding 1 pharmacist to your department will do.
We couldn't agree more. All right, Megan, what did I miss? What do you want to say as a last word to the folks out there? And how do we get every department to have an ED pharmacist?
Oh, that's part of my mission as starting this group within SAEM. I think that we've seen a tremendous amount of growth of emergency medicine pharmacy services. We have seen a lot of progress in recent years. So we've gone in for AMP from 3 members 3 years ago to almost 500 now. So we're growing really fast. There's really a need. We've seen a lot of things happen because of that. ACEP, we were able to serve on the ACEP ED accreditation panel and get all level 1 and level 2 accredited EDs have to have some sort of pharmacy coverage now, which is great. We had nothing before. We're getting integrated in a lot of ways there, but we still have a long way to go. So I would say any hospital without emergency medicine pharmacist services, they should consider hiring someone because we bring a lot in terms of patient safety and quality of care, prevention of adverse effects. There's literature to support that we reduce time to care in terms of time and appropriateness of antibiotics, analgesic sedation, anticoagulant reversals, thrombolytics. There's a huge return on investment when you're talking about cost avoidance, up to 10 times our salary that it costs to employ a pharmacist we bring to the table. We take care of antimicrobial stewardship initiatives for the department. There's data that shows that we save physician time every shift. So there's a lot of reasons to hire an emergency medicine pharmacist if you don't have that right now. And I'm really excited for what the future holds because I think that we'll just continue to grow across the country.
I love it. Thank you so much for coming on the show, Megan. And thank you for doing what you do.
Thanks for having me, Scott.